So we're going to be talking about UVCs or umbilical vein catheterization. So when do we do this procedure? On any newborn that is not turning around with ventilations or is in cardiac arrest. Who can do this procedure? An advanced EMT and paramedics can do this procedure because it is a peripheral line. Some contraindication for this procedure is going to be skin infection in or around the cord, or when you see bowel protruding from the cords. As you can see in this picture, a little bit of the baby's bowel is poking through and the cord is like right on top of it or right beside it. If you at all you see a presentation like that, we do not do this procedure. Supplies that you're going to need is an umbilical catheter, a string, stopcock, saline, iodine, gauze, and a scalpel. Iodine is going to be the preferred method of cleaning the area due to it is safe for all gestational ages. Here is a picture of your supplies. Here's another picture of your supplies just unwrapped. And with this catheter, as you can see, it's just a very long catheter. There is no needle in it. It is no different than a urinary catheter. Besides, there is no balloon. Along the sides, you will see markings that are marked in centimeters. So this is what your setup's going to look like. You're going to have a saline flush attached to the stopcock and the catheter attached to the stopcock. The stopcock is very important. It helps minimize air embolisms. It also closes this unit because if you didn't have that attached, it would just be an open unit and allowing pathogens to get to that baby. It would also help with dosing meds. As you know, we like to use stopcocks with neonate resuscitation. The other thing is you are going to prime this line. So make sure that this line is primed before you start this procedure. You do not want all of that air getting into the baby. So here are your landmarks that you're going to look for. The typical cord is going to look like a smiley face with 2 arteries and 1 vein. The vein is going to be significantly bigger. Some other ways that you can kind of point these out is if you squeeze that cord, the arteries will pop out like eyes and the vein will collapse in like a mouth. Also, typically the vein is going to have a 12 o'clock presentation, just meaning if the head's up here, it is going to be right here at 12 o'clock. Here's a picture of an actual umbilical cord. As you can see, the 2 arteries in the vein. Here are some other presentations you can have. This picture just kind of shows what's going on in that cord, and that is that those arteries are wrapping around that vein. You can also have a presentation like this where the 2 arteries are off to the side of the vein and the vein is literally in the middle. And even though this is rare, you can have 1 artery and 1 vein. And again, you can see that one is significantly bigger than the other. As you see the vein right there, it is bigger and also it's collapsed in. Here is a video of us performing this procedure. So some things I want you to kind of imagine here is this bottle is going to be the baby. So right here, that is where the umbilical cord and the baby meet. And right up here, this is, pretend like there's a clamp already clamped. So right now they're going to tie that string around the base, right where the umbilical cord and the baby meet, and it's just going to be nice and snuggly, okay? It does not have to be cinched down, and you don't want it cinched down because you want that catheter to be able to pass through. Once you get that catheter in, then you can cinch it down further, especially if there is excess bleeding. And this will stay on until a doctor removes it. So then you're going to cut just below the clamp, and you want like a nice straight segment. You don't want to cut too close to the baby because you want to be able to place a clamp if you need to. But you want to make sure you have a segment that isn't very windy or has a whole lot of bends or valleys in it. And as you can see here, when they cut, it's a nice straight segment. And then here you can see the face The ET face is what I like to call it. And as they squeeze it, you see the two arteries popping out and the vein collapsing in. Then after you cut, you're going to insert that catheter right into the vein, which again is the biggest vessel. And as you are inserting it, you're going to be pulling back on that syringe. As soon as you get blood return, you stop. You are deep enough. For typical babies, you only need to go 4 to 6 centimeters, and that is plenty enough for that kid. If you happen to go further than that and you think you went a little too far, you can pull back. Just again, as long as you're pulling back to make sure you have good blood return, you are good. Here is a picture of what it looks like. Again, you could see where the string is supposed to be, and you can use forceps to kind of have someone help hold that clamp. And again, you're just going to cut just below the clamp. Here's a picture of what it looks like when it's in, and you're just going to tape that down. So this is what it's going to look like when it's secured. You're just going to take your Tegaderm and tape it down. And you can either wrap the cord around, you can either wrap it around like shown in this picture. And if you feel like this segment right here might pop out or is at risk of popping out, you can put excess tape there. It is not a positional site, just meaning that you can tape that down as long as the tube itself is not kinked, it will flow. One of the things that can happen is called false tracking. False tracking is just when the catheter goes through the vessel. You will have major resistance with this, no blood return. It will be very obvious that you are false tracking. With that, you are just going to pull the catheter out and then reinsert it. If this keeps happening, you keep false tracking, look at your umbilical cord segment. Is there a windy knot or valley in the cord? Is it a straight segment? Because if it's not, just cut a little bit below that and then reinsert it and you should get in. All right, that's all I have for you.